Good afternoon, everyone. I'm Linda Dixon from the Lexington Veterans Association, and I am happy to welcome you to a presentation on wartime casualties, constantly improved civilian medicine. We extend a warm welcome to our fellow veterans who are viewing this presentation from the Edith North Rogers Memorial Veterans Hospital in nearby Bedford, Massachusetts. It's my pleasure to introduce our speaker, Dr. Michael Rosenblatt. Michael Rosenblatt knew he wanted to be a surgeon at 5 years of age. His father was a surgeon with an interest in trauma care, and he took young Mike with him on calls. After earning a BA from Wesleyan University and an MD from Jefferson Medical College, Dr. Rosenblatt received his surgical training in the Boston University Boston City Hospital Integrated Program. While at BU, he earned a Master of Public Health and a Master of Business Administration. He joined the Lahey Hospital medical staff in 1993, and he immediately became a key advisor in the creation of a trauma center at their brand new Burlington location. When the trauma center opened in 1997, Dr. Rosenblatt was named director, and he served in that position ever since. He also served in the U.S. Navy Reserve from 1987 to 98, excuse me. That's a decade there, reaching the rank of lieutenant commander. He served 10 years as an examiner with the Baldrige National Quality Program of the U.S. Department of Commerce, including 3 years as a judge for the Baldrige Award. It's my pleasure to turn the program over to Dr. Michael Rosenblatt.
Thank you, Linda. It's a pleasure to join you, even though it's remote. Linda and I first met each other back in the winter. I think it was in January. And we were planning on doing this presentation on March 12th. And we decided the morning of that presentation that it probably was not a wise idea to get 50 plus people into a room. And we decided to cancel. It was a kind of a last minute cancellation, and we apologize for that. And you guys contacted me again sometime in the summer, asked me if I'd be willing to do this, and I think I was given a November or a December option, and I selected the December option. And of course, we are in the midst of the second surge, and it's a scary time. We're in the process of deciding tonight whether we're canceling all of our elective surgeries. We've shut down about 50% of them. So we're finding a great difficulty finding not only rooms for patients, but this time around staff. The number of nurses that we have that are either out ill or quarantined is so much higher this time around, and that's going to make this all of a challenge. I'm not going to say anything more about COVID at this point. I don't think that the military has been able to give us anything on COVID. I think the logistics of distributing hundreds of millions of vaccines are clearly going to be influenced by the military, but that'll be a story for another time. What I'd like to talk about today is the lessons that we have learned from military experience that have directly translated into civilian medicine. And I'm going to start off with talking about World War I and World War II, but I'd really like to spend most of my time focusing on Korea up through the Iraq and Afghanistan conflict. All those who desire to become a surgeon should go to war. This was Hippocrates, and there's no question that that is true. Unfortunately, there have been great opportunities for both my generation of surgeons, but actually more so for the generation slightly older than me and significantly older than me. I was lucky enough to train with a series of surgeons that had kind of cut their teeth in Vietnam. And then there was kind of this quiet time, which was a blessing for all of us. And then, unfortunately, the first Afghan-Iraq time came along when I was a chief resident. And although I did get called up, I was sent packing back to my residencies because they thought that I wouldn't be of much help to them. So the goals of this talk today are to talk about the technical, the clinical, and logistical advances that we've taken from the battlefield and imported them into the civilian care, and to understand how we adopted these effectively. Now, in World War I, there were advances, and they were very significant. They were game-changing. But by the time World War I and World War II were over, they were kind of common. So the use of intravenous fluids started in and around World War I. Before then, you drank, you were given fluids per rectum, or you weren't given fluids at all, or they injected it underneath your skin. But it wasn't until World War I when we actually started to put needles into veins and infuse fluid. Obviously, the logistics improved because instead of having a horse-drawn ambulance, we had motorized ambulances. In terms of kind of clinical things, we started to do things like exploring an abdomen for a penetrating abdominal wound rather than doing what we call expectant care, which is wait and see what happens. And in most cases, if the patient got sick, you wouldn't even explore. World War I also brought around the development or incorporation of medical specialists. Now, this is kind of the back and forth between civilian and military. Clearly, most of the surgeons that were operating in World War I came from the civilian theater. The civilian population and went into the military theaters. The actual number of permanent physicians or surgeons in any of the branches is quite low, and they completely rely on the resources of the reserves. And it was in this period of time that we started to develop specialties in surgery. You weren't just a general surgeon that did everything from the brain to the bones, but you started to be a neurosurgeon or an orthopedic surgeon.
Hey, Michael, this is Jim Ramsey. Just a quick interruption.
Sure.
I noticed on the slide I'm looking at here that on the right side, there appears to be like a notes page and some other things. I don't know whether you're showing us the actual full screen. I just...
Let's see if I can get back to, let me switch around
and
here.
Again, that's better.
Is that better for you?
Yeah, now, I don't know about others. You've advanced to World War II, so obviously you want to go back, but I think that's better. Thank you.
Is everybody, same for everybody?
It's better for me.
Okay, perfect. So then there were some other clinical advances. For instance, the concept of antiseptic approaches. If you ever looked at some of the images that were done in the late 1880s, you'll notice that most surgeons either operated barehanded, or if they wore gloves, the gloves were really to protect them from the antiseptic, but they weren't wearing sterile gowns and things like that. So there was a much greater interest in antisepsis. And in fact, two surgeons, one by the name of Dakins and one by the name of Carrel, developed a wound irrigation system with some antiseptic agents. Remember, this was long before antibiotics were around. And this Dakins solution is made up of bleach and water and a couple of other things. This is still used. I use it probably on a weekly basis in my trauma patients. So this is an enduring change. There was, Carrel also, incidentally, in 1912 won the Nobel Prize in Medicine for his vascular surgical techniques that he developed in animal model. It wasn't advanced enough in terms of translating this to surgical techniques of the surgeons at the front line to allow them to use it. But as you'll see a little bit later, that Nobel Prize winning technique actually translated very well into future military care. There was anti-tetanus serum. There was another Nobel Prize connection in that Maria Curie won the Nobel Prize in 1903 for X-rays, and within 20 years, we're using X-rays in theater to try to identify foreign bodies. There was the first approach to trauma databases, and I'll talk a bit about this as a common thread. And the neurosurgical database that was developed here, I believe, was developed by Harvey Cushing, who was a very prominent neurosurgeon. I think he started at the Brigham and ended up at Johns Hopkins. And then finally, although there weren't any antibiotics at the time, there was a great interest in understanding the bacteria and the infection rates in wounds. If we move on to World War II, we'll see additional advances, and this includes the availability of whole blood, meaning blood that is basically taken from one donor and transfused into one recipient without separating it into its different byproducts like platelets and plasma and red blood cells. But they started to separate these different factors, and this is where we get component therapy, and that's where we get the plasma from whole blood. But they didn't have a way really to store platelets or the red blood cells separately initially. There was a development of some standardization around the care of burns. Now, burns are injuries that are really resuscitative injuries, meaning that you lose a lot of fluid, and that fluid is a combination of clear fluid and blood and other factors. And it was kind of a guesswork as to how much fluid needed to be replaced in order to prevent the complications such as kidney failure and just basically what we call hypovolemic shock, not having enough fluid. And so this was the initiation of both development of formulas to try to predict on the basis of how big the burn was, and developing maps of something that you could use very simply, like your hand, and that the body surface is composed of a certain number of hands, and when you measure the hands, if you have a burn on one upper extremity, that's the equivalent of a certain number of hands. That gives you a percent, and that percent would drive how much fluid you need to replace. And then in terms of organization, we talked about in the World War I where there were specialists. Well, now they not only were there specialists, but they were well trained. To give you an example, I had my grandfather, who was a primary care physician who graduated medical school in 1918, was guided to go to medical school in 1915 by his cousin, who had graduated medical school, did a one-year general surgery internship, and then went out into practice. And as he went on to become the president of the AMA in the 1950s, and my father was fond of saying that he was a better politician than he was a surgeon. And that's probably because he didn't have much training. But in the time between World War I and World War II, standardization of training programs came about, and surgeons were extremely well trained, and they were mobilized to different theaters, and oftentimes went with their teams. So they would have the hospital would mobilize, the Mass General would mobilize, the Peter Bent Brigham would mobilize, the Boston City Hospital would mobilize, and they would be go as a group to different places. There then became also a hierarchical organization of trauma care, which plays out to this day, of kind of a forward concept with combat medics brought then back to an aid station, and then subsequently brought higher up. Now this, and we'll get into this a little bit more in Korea, but it started out in terms of a hierarchy, and that has become incredibly complex and effective now. In the middle of World War II, Fleming had developed penicillin, and that started to become available in the late aspects of World War II. So immediately went from the lab into World War II, and then obviously came out of the military to the civilian areas. We started to see the use of fixed wing aeromedical evacuation to more sophisticated facilities. And then the identifications starting in World War II of some interesting concepts that were really related to kind of the first aid that was available in the field at that time, which was basically bandages. And then the ability to get that wounded soldier back to an early resuscitation where they placed intravenous fluids and were able to give the wounded warriors back blood and fluid. And soldiers that had been injured before that and didn't get that aggressive resuscitation would die. But now we started to see almost the secondary effects of the resuscitation in this wet lung in war. And this is a theme that will kind of expand through Korea and Vietnam. What's very, very interesting is kind of the pattern of why people would succumb during war. If you go back into before World War I, what you'll see is that most of the deaths that occurred in the combatants were non-combat deaths. They were non-hostile. They were related to infections and the things such as trench foot and the like. But as we kind of went into World War I, you'll see that some of the public health effects and the attention to detail with nutrition and improved equipment to keep people from getting ill, and just a greater understanding of that issue now results in the vast majority of deaths being due to combat injuries. And this brings us to some of the lessons learned from World War II. Elliot Cutler was a surgeon at the Brigham and had been obviously mobilized, and he was a consultant to the Surgeon General, as many of the prominent surgeons of the time, including Dr. Frank Lahey, were. And what Elliot Cutler realized was that if there was a delay in getting the injured combatant to definitive care, then the outcome was worse. And he urged the extension of moving the resources closer to the soldier rather than bringing the soldier to the surgeon. And this plays out as we enter the Korean conflict. So in Korea, we're all familiar with the movie and the TV program, MASH. And this was a concept that was thought about at the end of World War II, but the conflict ended in World War II. So this was a concept that was waiting for the next conflict. So in Korea, they started to develop these 60-bed, tent-based, truck-borne MASH units, and they were advanced to the forward location just out of enemy artillery range. And they weren't intended to have helicopters associated with them, but if you link the helicopters, the effect of helicopters and these MASH units, you can see that there was nearly 100% drop in nearly 50% reduction in the fatality rate. This concept of a compressed group that was ready to respond had really one focus, which was taking care of trauma patients, was very, very close to the action, and had kind of resources. And in this picture that you'll see next, there's really two different types of resources. You have both the ground transport and the air transport. You link those to a dedicated unit to take care of people, and that's going to affect outcomes in a positive way. So helicopter evacuation really evolved out of necessity. The Korean conflict was in rugged terrain, poor roads. There was frequently changing battle lines, and there was a group of air-sea rescue helicopters that their responsibility was to retrieve downed pilots, and they started to get requests from individual groups where they had somebody that was injured and they could not transport them without a helicopter. And the Army and Air Force cooperated, and in 1951, they created 4 helicopter detachments that were associated with MASH units. And their specific mission was to evacuate these seriously injured soldiers from the front lines, not to focus on retrieving downed pilots. And the helicopters were equipped with 2 external baskets or pods. And if you think about it, that's pretty neat to be riding on the outside of the helicopter. These are relatively small helicopters, but the problem is that both by altitude and by geography, Korea is quite cold, and they had to think about how they were going to keep their soldiers that they were evacuating freezing to death. So they started off with sleeping bags and plastic bags, and they diverted heat from the exhaust of the helicopter to try to keep the soldiers warm. They developed devices to infuse plasma from the helicopter through the door to the pods, and they developed warming systems so that the fluid could hang in the cabin and not freeze. And it was really kind of the necessity was the mother of invention in this situation. And the helicopters in Korea planted the seed, although it took another 2 decades really to have happen for what we have now, which is the civilian kind of medical helicopter evacuation model. And these are 2 helicopters from MedFlight, which wasn't organized until 1985, so after the Vietnam War. Now, in addition, in Korea, if you remember the developments in World War II, where we had red cell infusion and separation of plasma, we now had this issue. On the left is a picture of the glass bottle that would basically be used to store blood. And if you can imagine trying to transport a blood donation unit of blood from the United States to Korea, or even from someplace in Southeast Asia to Korea in these glass bottles, you can imagine first they would shatter. Second is the capacity is limited by the glass. You can't really compress it. And third, in bottles, red blood cells break down. They call what we call hemolyzed. So in Korea, during the Korean conflict, the blood was now packed in plastic bags, which doubled the shipping capacity and eliminated the hemolysis. In the Korean War, they started to think about what were the nature of the injuries that were injuring the soldiers. And this is a picture of an individual who developed a bruise from hand grenade fragments because they were wearing body armor. and they didn't get killed by that fragment. And basically, body armor was started to be developed in Korea, and this is an example, along with the blood and the blood bags, of something that's come directly to not so much civilian medicine, but civilian preventive medicine, if you think about it, because we now have body armor. So Dow Chemical was involved in development of body armor in Korea. They used a material called Duron, and it was effective at defeating 68% of missiles. That's Dow Chemical went on to develop other things. DuPont developed Kevlar, and I think for my own personal thing, one of the silver linings of this COVID epidemic is I've gotten to meet some people I never would have met and work with them. And one gentleman that I've worked with at Northeastern holds the most recent patent with DuPont for the most recent Kevlar. If you remember back in World War I, we had Alexis Carrel, who had won the Nobel Prize in Medicine for repairs of arterial injuries, which was all done on dogs. It wasn't really until Korea that vascular surgeons started to directly repair arteries, and they used the techniques that Alexis Carrel won the Nobel Prize for in 1912. We learned that you could repair arterial injuries with your own vein. Autologous vein is your own vein. So you basically take a piece of vein that you otherwise don't need and use it as what we call an interposition graft. It's sewn in place where the artery's been injured enough that it can't be reattached. And we also learned in Korea that the associated venous injuries, the vein injuries that often are associated with an arterial injury, since they lie pretty much directly next to each other, the artery over here and the vein right here, it's hard to injure just the artery without injuring the vein. But what we learned in Korea, with the help of some of the database work that was being done there, was that if you ignored trying to repair the vein and just tied it off because you wanted to stop the bleeding, and you would say, well, the blood is getting to the extremity from this artery. Well, you slow the blood coming out of the limb when you tie off the vein, and that results in more likely arterial repair failures and unnecessary amputations. So that was a lesson that was learned in Korea that is used on a daily basis in civilian care. Along in this period of time, we talked about the neurosurgery database in World War I. There were additional databases in World War II. And this is the introduction of computer record keeping in Korea. And they basically used punch cards and were able to keep track of battle and non-battle casualties in that way. This takes us to Vietnam, and in Vietnam, we still saw soldiers who were dying before they reached the MASH, and the MASH unit was beefed up in Vietnam, but as they observed people dying before they got to the MASH unit, or they may have not have completely died yet, but they were so far gone that there were opportunities that could be had out in the field. And in this way, they started to teach the medics to do more than just apply a bandage. And in this case, they taught them how to do what we call surgical airways, which are the equivalent of a tracheostomy. They taught them how to put a needle into the chest if they suspected that one of the lungs was collapsed and there was what we call a tension pneumothorax, where the collapse was so severe that it pushed on the heart enough that the heart couldn't pump. And that's easily resolved by simply putting a needle into the chest and allowing some of that air to escape. They also started to initiate what we call aggressive shock resuscitation. So they would carry IV fluids and start the IVs And the medics that were taught to do all of this came back and developed physician assistance programs in the civilian world. So advanced physician assistant providers and extenders, which obviously goes on to this day. Norm Rich carried on the work from Korea. Norman Rich eventually ended up being, I believe, the dean of the Uniform Services Medical School in Bethesda. And he continued all the work that was done in Korea in terms of vascular surgical outcomes. And that research database lives on. The burn lessons that were learned in World War II and Korea were advanced in terms of Vietnam with different types of techniques, better improvement in fluid management, different dressings. And then if you remember back in World War II, we started to discover this kind of war lung, and this was better characterized in Vietnam as what we call Acute Respiratory Distress Syndrome. Very similar to what some of the COVID patients are experiencing now, and requiring special treatment and special support back in the Vietnam days, much of which is kind of the cornerstone of what we're treating our COVID patients with right now in terms of ventilator management and putting people on their stomachs for half the day. Those were lessons that were learned directly from Vietnam. This is an article by my mentor, Erwin Hirsch, who was chief of surgery at Boston City Hospital when I was in training. And this is I think it's a 5-page article that he wrote on research lessons learned in Vietnam, where he ran the naval research lab at the Da Nang Naval Hospital. And obviously those lessons he brought back to Boston City Hospital, so directly related. Interestingly, the first paper that I ever wrote was on the frozen red cell program that he has highlighted on this first page. And I did that paper with the Naval Blood Research Laboratory, which at the time was on the campus at Boston University. Now, this translated in terms of the Vietnam experience to things such as emergency medicine as a specialty. Before Vietnam, the physicians that were in the emergency room would be called down there by the charge nurse. They wouldn't be stationed there. And if they were stationed there, they might be an internist that might be interested in doing this as getting an extra shift, getting paid by the hospital. Similarly, you might find a surgeon that might have an interest of spending their time there. But this really stimulated the development of emergency medicine as a specialty. It was the key component to drive the American College of Surgeons to develop their trauma center verification program. Before the trauma center program, before 1979 roughly, hospitals could basically say that they were a trauma center. And most of them that did it effectively, but other places could go out and basically say, we're a trauma center, and you'd be basically driving down the highway and see the H sign and it said trauma center, and you'd get there and there weren't the resources that were necessary to resuscitate people. So the American College of Surgeons, based on what they learned in Vietnam, put together a set of criteria that says this is what you need to have to be a trauma center. It started off with about 100 different elements, and I believe they're up to about 500 right now. And then the other thing that really was straightforward was the development of critical care fellowships. These are people that basically are interested in specializing in taking care of really sick patients. You can see them on the TV on almost nightly basis right now during the COVID epidemic. Most of them are pulmonary and critical care fellows, but there is a whole branch of surgical critical care that really didn't exist as a formal component before Vietnam. This is Erwin Hirsch. He was chief of surgery at Boston City Hospital pretty much from when he left the military until his untimely death in 2008, where he unfortunately drowned up in Maine. You know, he was the epitome of a mentor, as outlined below here. Because of that, he was the person that brought the concept of med flight to Boston. He hired to Boston City Hospital Dr. Suzanne Waddell and Dr. Alistair Kahn, who had basically joined Boston City Hospital in 1985 as the directors of what was the nascent med flight coming from Maryland shock trauma. Alistair went on to be head of the emergency room at MGH, and Suzanne was the president and chief medical officer of MedFlight until she passed away 3 years ago. And if you'll notice on this helicopter, this is a unique number. N72EH is 72 was how old Erwin was when he passed away, and EH are his initials, and they had to get special permission to number this helicopter that way. And my connection with Erwin and the military is that he basically in my swearing in ceremony, he basically swore me in on the Constitution. So I have you know, fond memories of Erwin. So let's move on to Iraq and Afghanistan. These are the tourniquets that our combatants went out with at the beginning of Iraq and Afghanistan. And what they had discovered in that period of time, when they started to evaluate the deaths, was that 50% of the combat deaths were due to uncontrollable blood loss. They had some advanced body armor, as many people know, but the extremity injuries and what we call the junctional injuries at the groin or at the shoulders were really the things that were really killing people, other than head injuries. Now, because they went through this process and discovered this, then they went back to the drawing board and they developed what they call the Combat Application Tourniquet, the CAT tourniquet. And this was developed in 2007 through 2009, introduced in 2010. And it was estimated in that conflict that between 1,000 and 2,000 soldiers' lives were saved. And you can see that the uniform really came with this built-in a way. And you could have one on all four of your extremities without really cinching it up, and you wouldn't even know it was there. But through the buddy system or yourself, you can apply your own tourniquet. This translated in terms of civilian work into what the American College of Surgeons supports is the Stop the Bleed campaign. And we've actually trained 3,000 when I first put this together a year ago, and probably this holds true right now because we had to stop due to COVID. But we've trained over 3,000 first responders in stopping the bleed. It's the equivalent of basic life support and CPR for the surgeon. We have somebody that comes in once a month easily with a tourniquet up that's certainly contributed to their stability. In addition, there's been development of special dressings that, in this case, this is a dressing that has shells of shrimp and lobster that are impregnated in the gauze. And if you stuff it in place into an open wound, it'll slow the bleeding down significantly and buy people time. And that's what we're talking about in terms of really treatment, because one of the things that really became more prevalent because of Iraq and Afghanistan was what we call damage control resuscitation. Now in Vietnam, one of the lessons that we learned here in Vietnam was to sometimes that doing less is more, meaning that rather than going in to a soldier that's been shot in the liver, the spleen, and multiple holes in the colon and the small intestine, that rather than trying to operate to completion, if you just temporarily do things and do what we call a damage control surgery, packing off the liver, not trying to resect the damaged portion, stapling off the intestines but not hooking them back up together, getting them to the intensive care unit where you can straighten out their blood, their bleeding disorders, warm them up, fix their acid-base bounce, and then take them back to the operating room in 24 or 48 hours. Your outcomes in terms of mortality were much improved. That was Vietnam. Now what we're talking about is extending this to what we call damage control resuscitation. If you recall, I said that in Vietnam, one of the approaches that the combat medics had was that they had fluid and plasma, and they could initiate aggressive, and that's the term, aggressive resuscitation. That aggressive word was actually in the advanced trauma life support course up until the mid-90s. And then it got switched over to what we call judicious, because we started to learn in the civilian world that if you're not real aggressive, then you can basically be more successful at resuscitating people, because you want to stop the bleeding. And if you stop the bleeding, then resuscitate them, you're going to be better off. So we went into damage control surgery, and it went back and forth from Vietnam to Afghanistan. And this is a picture of temporary surgical approaches, where we're basically, instead of trying to repair this vessel, we're putting a shunt in. Instead of closing the abdomen, we're putting packs in and coming back to fight another day. Now I'm going to finish up with some of the logistics. I know time is running tight here. But the logistics are, if we talked about kind of the paramedics way up in front and then the combat aid station, each of this is a long chain, and that chain basically takes the patient from the point of injury to the forward surgical team to the in-theater hospital to the next series of more major hospitals. And this is done by helicopter, by fixed air. This is an example of kind of the front lines. The surgeon on the left, far left, is one of my partners, John Way, who's a captain in the Navy, and he's assigned to a forward operating facility when he goes out in the field. And these are the echelons of care, and what you can see here is that in the forward team, they have 2 operating rooms. Their job really is to stabilize, do damage control, and transfer. They transfer back to a combat support hospital, and then those soldiers are then transported back to either through Langstuhl in the Middle East and then back to the continent. This is the mobile ICU, really. On the left, you can see that most people look like they're pretty good, but here's a picture of somebody that's quite sick, basically in an ICU in the air, and you couldn't tell that this wasn't in a hospital. And they were dealing with the exact same problems in terms of maintaining warmth that the helicopter transports in Korea were. Different war, same problem. And it's basically about improvisation. In terms of of lessons learned, this is where it got very, very interesting in that they actually sent out groups of experts into the field to try to evaluate when things didn't go so well and when they did go well. And they basically captured, in order to standardize, 43 different clinical practice guidelines. They had video conferences across 3 different continents, and the results of this were pretty impressive. The dark blue line is the injury severity score. The higher the number, the sicker you are. And you can see that despite the injury severity score rising, the case fatality rate in Afghanistan improved over that period of time because of the improvements that they put in place. Now, the integration of military and civilian trauma really has been formalized by the National Academies of Science, Engineering, and Medicine. And there is an effort afoot to basically translate back and forth in a very systematic fashion to try to reach what we call 0 preventable deaths. Some of the more obvious things in terms of blood products we've been talking about since World War II is the advances that occurred in Iraq and Afghanistan in terms of the ratio of blood products. In terms of component therapy, you want to get basically the equivalent of whole blood, which is very, very hard to maintain in terms of a blood bank, but you can put it together in terms of component therapy, trying to push the ratio as close to normal as possible. And what this basically shows is that if you have a balanced resuscitation with a 1-to-1-to-1 ratio, as opposed to giving people a lot of red blood cells, but not the other factors, plasma and platelets, the outcomes are significantly better. And that translates into needing to expect that every trauma center has what we call a massive transfusion protocol. Additionally, adding in some types of things that were used like tranexamic acid. Nobody knows how it works, but it seems to work in improving outcomes. This has been adopted by our pre-hospital colleagues. So if somebody looks like they're bleeding, they get a shot of TXA out in the field. And then in terms of prevention, if we can avoid the injury altogether, then we're going to be much better off. And there's been very, very sophisticated analyses of prevention. And for the sake of time, I'm going to skip through all of this, but there's a whole long list of things that have been done based on analysis of injuries to say this is what we need to improve on things to try to avoid these injuries altogether. There's advances in terms of pain management that have trickled back to the civilian side. And in fact, a good number of the anesthesia pain specialists are military trained. And things like prosthetic limbs, you know, it's obvious that these are the types of things that we learn best from the military. And then finally, we're not thinking about, really, the military is not thinking about fighting the last war. They're looking at different scenarios in terms of what it's going to take and trying to understand how military medicine is going to have to adapt and adopt to this. And I'm sure that we're going to learn some things from future encounters that we'll bring back to the civilian side. Some of those future innovations include freeze-dried and cryopreserved different products, development of blood substitutes, advanced hemostatic agents, and then things like clinical decision support tools based on very specific individual biomarkers. We're learning an awful lot about that not every person is the same, and they're going to respond in different ways to different injuries, and we may need to fine-tune what we do. So in conclusion, I think it's very, very clear that military medicine improvements, both clinical, technical, and logistic, have migrated back and forth to civilian and then from civilian back to medicine, and it's not surprising given the interaction between the providers in both areas. For those of you that want to learn a whole lot more about this, I strongly recommend this book. It's really a pamphlet put out by Fort Sam Houston, Out of the Crucible, and this is the website that you can download. I think it's 500 pages of fascinating reading. And with that, I think that's the end of my slideshow.
Well, okay. Thank you, Michael.
So Michael, okay, good.
Yeah,
Sure.
that was super. And now we're going to entertain some questions. And the very first one I'd like to start with just happens to be, you're gonna like this, happens to be from a gentleman we know and love, Ed Loturco. Ed was an aeromedical evacuation specialist in the Vietnam War. And he put patients on aircraft and he took them to hospitals. So he has a question in the chat line, but I'm going to ask Ed to ask his question in person because I think it's going to be great that a member of the actual trauma system be on here talking to you. So Ed, if you're there, we've unmuted you. So why don't you ask your question?
I think Ed needs to unmute himself at this point.
He does. This is Christine. I gave him permission to talk and I asked him.
Unmute yourself, Ed.
Got it now?
Yeah.
Okay. How are you, Doctor? It was an excellent presentation.
Thank you,
Don't
Mr.
forget your
Lockhart.
video. Turn your video on.
Didn't know I had that off. Oh, where do I turn video on?
We want to see your lovely face.
I have to promote him to panelist to let him turn the video on. Just a second.
Oh, okay. 1 sec.
Now, Ed, you should be able to turn on your video.
There we go.
Thank you.
There we go. Again, thank you, Doc, for an excellent presentation.
Thank you.
I think probably at the tail end, if I had waited to ask my question, you pretty much hit on it. I would absolutely believe that what I learned specifically was how we have done that transition from war zones to in-the-air evacuations to actually learning as much as I did to be able to place myself into a situation in an emergency room in Malden Hospital when I got out of the service. And I think I applied all of those instincts in a very great way that I did become the first EMT here in Massachusetts, which kind of set the ball rolling to what we see in PMTs today. So I do concur, but is there something that is not as important as what we've learned from the military world and medical that stands out as the most successful thing besides trauma here in our civilian world?
Besides trauma, well, I think if you go back to the graph that I talked about in terms of the mortalities were due to non-trauma conditions beforehand, and they were strikingly much higher than what was actually occurring from the trauma. That's a public health approach. The way they got to that was a public health approach, and I think that's in terms of keeping your troops healthy is the best way to keeping them alive and keeping them safe water, safe food, safe shelter. That's really how they were able to accomplish that. And I guess maybe smarter things like not doing a Napoleonic march through the middle of the winter, that kind of thing. So outside of trauma, I think prevention is probably the biggest lesson that we've learned from them.
It's a good one to share. Again, I thank you.
Well, thank you.
Okay, thank you to Ed. So Bob Lewis wants to know, would you please tell us about what a wet lung casualty is? Sure.
So if you remember, I said that in Vietnam, in World War II, they called it wet lung. In Vietnam, they called it that Acute Respiratory Distress Syndrome, ARDS. And that basically is the result of leaky capillaries. Those are the connections between the arteries and the veins that start to break down and allow the water that's traveling or the fluid that's traveling in the bloodstream to leak through those leaky capillaries. When that happens in the body, in the skin, you'll see people swell up. When the blood passes through the lungs, there's really nowhere for that fluid to go except into the lung, and the lung predominantly is air. It's a sponge with a bunch of air cells. That fluid accumulates in those air cells, and that becomes the wet lung. And the treatment for that is to try to avoid the leaky capillaries if you can, and the way that you do that, similar to preventing something. Well, the injuries occurred, can you prevent secondary harm like infection? And then kind of approaches to how much fluid you give, what kind of fluid you give, and what kind of respiratory support you give in terms of pressure in the lungs that you want to apply to force that fluid back into the bloodstream.
Okay, thank you. Phil Cunningham is interested in PTSD and wonders if you can say something about innovations in the treatment of PTSD.
It's a stunningly important question. And I'm not on the innovations side for treatment. I think right now it's, we're from the civilian side, in our population, we're trying to, the same as the military, trying to have a better way to identify it. That's number one. Number two is to try to reduce the stigma associated with it. And thirdly, get people to therapy. Now, again, I'm not a psychotherapist, so that I can't address any of the improvements for treatment of PTSD, but I think it starts with, like any other disease process, you have to, recognize that it exists. We're actually, the American College of Surgeons for the trauma centers drives the agenda for civilian trauma care. And the first step is to screen for it. And that's not as easy as it sounds, because there's something called acute reactive process, which very much overlays PTSD in the first month or so. It isn't until 3 months out that you can actually define it as PTSD. In the military, there's an advantage because you're hanging on to those patients because they're in a system which they are part of. When we have civilians, they leave the hospital and we may never see them again. So we have a challenge screening for that.
Follow-up question, is PTSD considered a battlefield injury?
From the military perspective, I can't answer that question. I would think so, though. But it's not uniquely a battlefield injury. I can tell you that we, right now in the middle of this pandemic, many of the healthcare workers are experiencing PTSD, and that we're actively trying to identify and provide a route to get people treated. So if you would say that we're in the middle of a battlefield, then it is a battlefield injury.
Okay. Bill Poole has raised his hand. Bill, we're going to unmute you. Do you want to give us your question?
Can you hear me?
Yes.
Yeah. Dr. Rosenblatt, thank you. That was amazingly wonderful.
Thank you.
I guess one of the things I want to say is it's impossible to quantify the benefit to the civilian life of the military development in medicine and so forth. Of both people coming back from the military service to then work in the civilian service like Ed did, and thank you, Ed. But the other thing is that things are happening in civilian life the same way they're happening in military life, not wounds from shrapnel and so forth. But I've read that during World War II, there were approximately 15,000 amputations, military amputations, while at the same time in civilian life, there were well over 100,000 amputations. And so things that were learned on the battlefield in helping soldiers and so forth would prove beneficial to at least 10 times that factor here. And I'd say we're up to 100,000 times the degree of benefit to civilian life from military, what's happening in the military.
100% agree. And it just keeps on giving, because the techniques that are used in your example, the techniques that are used to prevent the need for amputation are used on a daily basis for injuries of that kind. And maybe not, it doesn't even need to be an injury. Many of the times that we use, for instance, damage control surgery may be on an emergency surgery procedure that has nothing to do with trauma. So the payoff is tangential. It's not even just limited to the trauma care.
Okay, now let's see, are there any more questions? I don't see any in the chat.
Hey, Linda, this is Jim.
Yes.
I saw briefly on a Q&A that someone had asked whether it would be possible to get a copy of Michael's presentation. They took the question down.
I've just written him a note, but go ahead.
Okay, well, if you wrote them a note.
No, but other people may have the same questions, so you provide the answer.
I guess I would say that Michael, you ahead of time here, you sent me a copy of your presentation. Would you
share it with anybody you want?
Okay, well, I guess what I would say, one answer to the question would be, if someone wants to contact me, I'm at James Rams, like my name, JAMESRAMS @verizon.net. And if you'd like a copy of Michael's presentation, I'll send it to you. You're sure that's okay, Michael?
Yeah, absolutely fine.
Also,
okay.
This program will be posted on YouTube very shortly, probably within the next, week or two?
Actually, that's the much better answer. Sorry.
And it will be accessible on the Lexington Veterans website. So
yes, and then you'll have the narrative as well as the
not only
slide.
will you get the slideshow, but you will get Dr. Rosenblatt in the flesh, which would be ever so much better.
Yeah,
so
that's the right answer, Linda.
Patients, you can see the whole thing in just a few days. Okay, Christine, I don't think we have anybody else in participants who has raised their hand, right? I think we're all set. We let you off easy, Michael. Wait a minute, there might be a third question coming up.
It's just a thank you from Phil Cunningham.
I see. Okay. Well, I think that does it.
Thank you very much.
Well, I knew it took long enough. Our relationships lasted almost a year, but we made it, and it was so worth it. Thank you so much, Dr. Rosenblatt, to take time out in the middle of this incredible surge, lockdown, horrible situation that's going on.
Well,
to give
everybody have a wonderful holiday and a better New Year.
Yes, thank you again for a wonderful presentation. Thank you to everybody. Best wishes for the holiday and for the new year. Today was an incredible red letter day. 2 important things happened. The vaccine got delivered. I hope we all watched it on TV. The beginning of an end to this pandemic. And we elected our president, which is a wonderful thing for the country. So good luck to everybody. Happy New Year. We will see you in January. Thanks for tuning in. Goodbye.